Good evening and welcome to Wednesday Wellness, a free live educational series brought to you by Trinity Health. We're thrilled to have you with us as we dive into learning about transforming your health, everything you need to know about bariatric surgery. Before we get started, here are a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A chat feature located at the bottom of your screen, and our presenter will address these questions at the end of the session. Lastly, today's webinar is being recorded and a link to the video will be sent to your email in the coming days. Without further ado, it is my pleasure to introduce our presenters, Dr. Brian Gluck and PA Tricia Anderson, who both bring 25 years of expertise on this topic.
Hi, well, thank you for having us and welcome everybody. Thank you for attending. My name is Brian Gluck, as Megan said. I'm a bariatric surgeon and medical director of bariatric surgery at Trinity Health, Muskegon. I started the bariatric program almost 25 years ago. I was the third one in Michigan to perform bariatric surgery laparoscopically and have performed over 7,500 bariatric surgery cases. Here at Life Without Limits, we have an expansive program that includes surgical and non-surgical therapies for weight loss with a multidisciplinary team, which includes the surgeon, special trained physician's assistants, dietitian, psychologists, and master's prepared social workers. We are accredited by the American College of Surgeons for Bariatric Surgery Centers of Excellence and a Blue Cross Distinction Center for bariatric surgery. As you will see throughout this talk, I am a much better surgeon than I am public speaker, so don't be alarmed. So how do we measure obesity? Obesity is measured by the BMI, which is the weight in kilograms divided by height in meters squared. And obesity is a complex chronic disease characterized by excessive body fat accumulation that presents a risk to health. It's not just an imbalance of calories to calories out. Hunger hormones such as ghrelin and leptin, as well as sex hormones, regulate appetite and energy expenditure. Obesity runs in families. Genetics play a big part and account for 40 to 70% of individuals' susceptibility to obesity. Diseases such as thyroid disease, type 2 diabetes, polycystic ovary disease, depression and anxiety, as well as Cushing disease play a part in obesity. Body barriers to health cause obesity, such as exercise-induced asthma, congestive heart failure, orthopedic injuries can also prevent exercise, which can cause obesity. Medications, especially antidepressants, cause obesity. And even altered gut hormones, gut bacteria, even play a significant role in influencing obesity. Obesity is an epidemic. Since 1990, the rate of obesity has doubled in the adult population, and even more importantly, adolescent obesity has quadrupled since 1990. Nationally, almost 50% of the adult U.S. population is obese. America is the heaviest nation in the world, and the rate of obesity continues to rise. Every body system is affected by obesity, from strokes, pulmonary disease, fatty liver, gallbladder disease, diabetes, hyperlipidemia, hypertension, and even cancers, breast cancer, uterine cancer, cervical cancer, pancreas cancer, to name a few. So lifestyle modifications are important to helping obesity, but it's not all just that. But even just a 5 to 10% weight loss can improve cardiovascular risk. Diet and exercise alone, though, has a 95% failure rate for long-term weight reduction. Why? some people think it's this set point theory. So when you go on a diet, it reduces you reduce your calorie intake, your physiology, um, in order to handle this effect, causes these obesogenic hormones to proliferate, and the body just wants to slow down. The metabolism slows, your energy balance slows, um, and the body is trying to keep its weight as it was, so you get weight regain. Here's a better way of understanding it.
Let me introduce you to Amanda. You're just meeting her for the first time, but chances are you're already making assumptions about how much she eats and how little she exercises because she's obese. But I'm about to show you that there's much more than meets the eye when it comes to obesity. There are lots of Amandas out there, and they need treatment. Maybe you're one of them, or maybe you know an Amanda. It's time to act on obesity. But in order to do so effectively, we need to understand obesity. It's generally accepted that body weight is determined by a pretty simple formula. We call it the energy balance equation, and it works like this. If the number of calories that you consume equals the number of calories that you burn, your weight remains the same. If you consume more than you burn, you gain weight. And if you burn more than you consume, you lose weight. Most people think that those of us who properly manage our energy balance remain lean, whereas those of us, like Amanda, who eat too much and exercise too little, become obese. We view obesity as a lifestyle choice, and the cure for it is simple: eat less and exercise more. This may sound logical, but it's wrong. Let me explain. First, let's talk about set point. No, I'm not talking about the point in a tennis match when one player is about to beat the other. I'm talking about a theory that says that no matter what you consciously want your weight to be, your brain has its own sense of how much body fat it should have on board, and it has a complex system in place that very precisely regulates your energy intake and expenditure to keep you within a so-called set point range for body fat. So that whole energy balance equation, it's not something that you control voluntarily. Your brain regulates your calories in to your calories out for you. For your brain to do this, it needs to know how much energy you have on board at all times, and it knows this by listening to hormones like leptin, which is made in your body fat. You can think of it like a car. Leptin is the gas gauge that tells your brain how much gas is in your tank, but leptin is just one piece of the puzzle. You've got a whole bunch of other hormonal signals and sensors that are involved too. Your bones, muscles, pancreas, liver, GI tract and sensory organs, they all play a role, communicating with your brain to give it the information it needs to do its job. But that's more detail than we need for this conversation. The point is that you have a complex system in place that regulates you to within a set point range for body fat. So what happens if Amanda decides to lose weight by going on a diet? After all, people with obesity should eat less, right? Here's what happens. She loses weight, but her hormone levels change. Her brain hears this, and it starts acting to restore whatever body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning fewer calories than before. You see, set point is usually a one-way street. Once it's been elevated, the brain works to defend it just as vigorously as it would a lower set point. Amanda's brain doesn't know that she needs to lose weight. It only knows to defend her current set point. Back to our car analogy. Amanda can't help but look for a gas station to refuel when she sees that her gas gauge is low. At the same time, she becomes more fuel efficient, burning less energy than before. This might explain why treating obesity with diet and exercise so often fails to produce the desired results. It's sort of like telling Amanda that she needs to be a more careful driver, when the real problem is that she needs a mechanic to fix her car. Okay, so if we've all got this complicated system in place that prevents us from losing weight, why doesn't it also protect us from gaining weight and developing obesity in the first place? How can we explain the obesity epidemic? Getting back to Amanda, why did she develop obesity? The answer is that it takes a perfect storm to cause an obesity epidemic like the one we're seeing now. And it's our modern environment that places us, and Amanda, directly in the path of that storm. While there's no single cause for the rising rate of obesity, changes to the chemical and nutrient content of our food, the so-called Western diet, a decrease in physical activity, increased levels of stress, inadequate and disrupted sleep, and more widespread use of medications that promote weight gain all play a role. Our unique genetics and developmental histories cause each of us to respond differently to these elements of the modern environment, and some of us, like Amanda, respond by sending hormonal signals that elevate our set point for body fat. It's not that Amanda's system has stopped working, it's just that it's working to regulate her to a set point that's too high. So you can think of obesity as a biological response to the modern environment, a disease where the body dysregulates to a body fat set point that is too high. Back to our car analogy. The size of Amanda's gas tank has expanded, so she carries around too much fuel. So now that we've looked at one of the theories behind why obesity occurs, let's look at theories of how it occurs. It's often assumed that obesity in people like Amanda is a result of a massive imbalance to their energy balance equation, that their intake vastly exceeds their expenditure. But is this always the case? Consider this. If you're an average person, you consume about 900,000 calories per year. And it's true that you need to burn 900,000 calories to avoid gaining weight. If your energy balance were to be off by only 4,000 calories, an error term of less than 0.5%, you'd gain a pound every year. If you break that down, we're talking about a mismatch of 11 calories per day, the equivalent of approximately 2 potato chips. If your intake were to exceed your expenditure by just 40 calories per day, the equivalent of 1 pretzel rod, you'd gain about 150 pounds between age 25 and 65. So there are 2 points here. 1. If you're maintaining your weight, you're doing so because your body is matching your energy intake to your energy expenditure more precisely than you could ever do consciously. So it stands to reason that your system plays a role in doing it for you. And 2, people may gain weight not because their energy intake wildly exceeds their energy expenditure, but because of a very slight mismatch between the two. For Amanda to lose weight and keep it off, she needs to find a way to lower her set point. That is, rather than declaring war on her own biology, she needs to find a way to make her body regulate itself to a new, lower weight. One option for Amanda to consider is bariatric surgery. In study after study, it's been shown to be the most effective long-term treatment of obesity. But how bariatric surgery works is often misunderstood. Most people, even many doctors, think of bariatric surgery in terms of restriction or malabsorption. It's a reasonable assumption that surgery would work in these ways. After all, the procedures usually consist of some combination of altering stomach anatomy to be smaller, which you'd think would restrict the amount of food that you'd be able to eat, and rerouting the GI tract in a way that you'd think would make you fail to absorb the calories that you do eat. But new research suggests that certain types of bariatric surgery, for example, gastric bypass, sleeve gastrectomy, and duodenal switch, affect the signals between the brain and the body to decrease appetite, increase feelings of fullness, increase metabolism, and even encourage preferences for healthier food. Surgery may change the set point for body fat. It's like the anti-diet. Instead of fighting the set point like a diet does, surgery may recalibrate it, and the hormones that stimulate weight gain when a person diets do the exact opposite after surgery as the body regulates itself to the new lower set point. So here are 3 things you can take away from all of this. 1. Energy balance is complex and highly regulated. 2. Obesity is a disease where the complex system that regulates body fat may dysregulate to a set point that is too high. 3. Bariatric surgery may work by changing the signals that regulate body fat set point, enabling patients to successfully lose weight and keep it off. It's time to reshape the conversation about obesity. It's time to look past diet and exercise as the only treatment solutions. It's time to act on obesity. And now that you've been educated, here's a simple way for you to act. Share this video. Let me introduce you.
So surgery is basically the first GLP-1, the original GLP-1 there was. Surgery is not only Ozempic, with GLP, but surgery has all the hunger hormones in there that you remove, and people aren't hungry. So When you diet, your appetite increases. After surgery, it decreases. The hunger decreases. Your feelings of fullness after surgery will increase, whereas when you diet, your feelings of fullness decreases. Your reward-based eating, the want for sweets or fatty foods with dieting seems to increase. After surgery, it decreases. Even your energy expenditure after surgery will increase, whereas with dieting, it, as we showed, it decreases. Stress response as well. So two common bariatric surgeries I perform. One is a gastric bypass, and this was first done all the way back in 1966, done open. And then sleeve gastrectomy came on later, but it was even done, the first one in 1998. A gastric bypass consists of creating a small pouch of stomach, then transecting, cutting the intestine into bringing the furthest portion up to drain that pouch and reconnecting you further down to the digestive enzymes. So you can't eat a lot. Some of what you eat doesn't get absorbed. You get some malabsorption. Digestive enzymes then come in here and things get absorbed. It changes all the hunger hormones because these are where the ghrelin and GIP and GLP-1s, these exist here. And so because food doesn't get in there, ghrelin levels decrease. I have some people after surgery telling me they have to remind themselves to eat. Risk with any surgery. Bariatric surgery has certainly become very, very, the risks have gone down significantly. There certainly can be staple line leaks. You could get ulcers at the connection called a marginal ulcer because you still have some gastric acid here, and the intestine here doesn't like that acid. That's why we ask you not to smoke, not to take anti-inflammatories after this surgery, because it can cause an ulcer. That ulcer could potentially bleed or perforate. You could get a fistulous tract between the gastric pouch and the remnant stomach, the old stomach. Because we reroute the intestine here, that intestine could twist, can get a blockage, causing a hernia, an internal hernia blockage. Anytime we do surgery, you could regain your weight back if you're not doing what you need to do and not following up with your bariatric surgeon. But really, the complications have become quite low, and most studies show that bariatric surgery is as risky as having your gallbladder out. Sleeve gastrectomy is another procedure I perform. When we create a sleeve, we make a tubular stomach. We take out about 80% of the stomach and create this tube of stomach called a sleeve. Now in here, in the portion we take out, again, we take out those appetite stimulating hormones. So again, most people say I have to remind myself to eat. Complications with this as well, any surgery, anytime we do surgery, you could have bleeding, infection, anesthetic problems. Big thing with sleeves can be leaks. Again, the leak rates have gone down tremendously, probably nationally less than 2% leak rate. Again, with this, you don't have any risk of bowel obstruction because of surgery or any micronutrient deficiencies. With this one, you could also take your anti-inflammatories. But again, with any bariatric surgery, it's all about long-term follow-up and sticking to your dietary habits. So bariatric surgery has unique mode of action that allows a metabolic change versus caloric restriction. It has the greatest weight loss results of any treatment options, certainly including the GLP-1 drugs, the Ozempics, the Wegovy's. It has the longest weight loss duration of any treatment. It has the ability to reduce or resolve comorbidities, high blood pressure, heart disease, sleep apnea. and it's shown to significantly improve quality of life. Next up is Tricia. Tricia's going to take it from here.
All right, I get to talk about some of the outcomes of bariatric surgery, and we'll get into the good stuff here. First of all, what we do surgery for, obviously the weight loss. When you look at RYGB is Roux-en-Y gastric bypass, after 1 year, we see about 72% of the person's excessive body weight coming off from them. Comparatively, a sleeve at 1 year is 66%. Keep going out year 2, we're 71% excess weight loss versus a sleeve is 65, and then year 3, we're settling in at 68 and 61. The weight gain that we're often seeing here between year 1 and 3, sometimes that represents muscle loss that's improving over the time. You go on a pretty restrictive diet as you're healing from these surgeries, and it's not uncommon to lose some muscle mass, and then come year 2, year 3, you're able to bring that back as your calories increase and your activity levels increasing. So pretty significant numbers. To put that in a frame of reference, if you have a 280-pound 5'5" female, the healthy weight for her is 150 pounds, 130 pounds overweight. And so if you said, what if she lost between 61 and 68% of her extra weight loss, she'd be down 80 to 90 pounds 3 years post-operatively, bringing her down under 100 or under 200 pounds, which is kind of that wonderland that patients look for. The weight loss, of course, is super impressive, and the scale often drives what motivates people. However, more importantly, for your life to be extended is to look to improving these weight-related comorbidities. And Dr. Gluck showed you some slides about that. Hypertension, diabetes, high cholesterol, sleep apnea, all very common problems in people who carry too much weight. When it comes to hypertension, pretty significant improvement and resolution of those. When you combine resolution and improvement, we're looking at 95 to 98% between sleeves and Roux-en-Y gastric bypasses for improving and resolving those. Diabetes resolution is huge. If you're somebody who struggles with your weight and you're dealing with diabetes, you absolutely should be considering bariatric surgery. The improvement in resolution rate is in the upper 90s for percentage. Hyperlipidemia, 93 to 96% improved or resolved. Sleep apnea, 97 to 98% improved and resolved. So what this really means is your lisinopril goes away, your metformin goes away, your insulin goes away, your statins that cause body aches go away, your CPAP machine that your partner loves so much goes away. So this is equally, if not more important than the numbers on the scale for folks. Early on, Dr. Gluck showed you a picture of a comorbidity list, and this kind of looks at after bariatric surgery. We just talked about high cholesterol, high blood pressure, metabolic syndrome, diabetes, but here's another important one, fatty liver disease. This can cause damage to the liver, which can contribute to cirrhosis and death. Polycystic ovarian syndrome, very common in women who have excess weight on their body. This can affect the periods, but equally problematic as it can affect fertility in women. So when you have bariatric surgery, you can see 100% resolution of menstrual dysfunction, meaning that your periods return to normal, which improves your ability to get pregnant after surgery. Another big problem that patients come in with is osteoarthritis, joint pain. Carrying this extra weight on your joints can be damaging and cause significant pain. So getting the weight off can be a real hopeful thing for that. When you look up to the left corner of this, we've got 95% of patients reporting dramatic improvement in their quality of life. And then when it comes to a relative risk of mortality, bariatric surgery reduces that 89% over a 5-year period. So we talked about the excess body weight loss being upwards 60, 70% for the bariatric surgery. looking at it in a different way would be how much percentage of your weight did you lose? And those are different numbers. If a person is 300 pounds and they lose 35% of their weight, they're going to be just under 200 pounds after their surgery. And this number I bring to light here because as I move forward in my slides, I'm going to kind of compare surgery to some of the medicines that have come out, and those are measured more in total weight loss or body weight loss versus excessive fat on your body. This, I think, is a great number. When you look at patients who report that they're very satisfied after bariatric surgery, we're close to 90%. I tried to find a better slide that showed not just very satisfied, but satisfied to be included. And when you included satisfied and very satisfied, it was 98% of patients. So as we look at the surgery itself and kind of the risks of that, and we look at the resolution of comorbidities and the weight loss, what's next is, are you a candidate for surgery? And the ASMBS has set forward some guidelines of who should have bariatric surgery, and that's listed here. I mentioned if you're a diabetic and you carry excess weight, you should absolutely be considering bariatric surgery. A BMI over 30 would qualify you for surgery. 35 or higher with other comorbidities such as the hypertension, sleep apnea, high cholesterol, and then a BMI of 40 if you don't have weight-related diseases yet. I kind of say these are the ASMBS recommendations. However, all insurance companies, as we know, don't necessarily follow medical recommendations, and we can help you to figure that out when you come to the office or when you meet with a bariatric team. They can help to make sure that your policy will cover it. Some bariatric or some insurance policies will require that you participate in a medical weight management plan if you haven't already done that. Bariatric surgery, before you have that, we'll have you do a behavioral health evaluation. We want to make sure that you're able to make that big decision to have surgery and that you're committed to a lifestyle change in order, one, to be safe after surgery, but also to get what you want out of it. Every patient, at least that comes through our office, goes through some rigorous dietary education before they have surgery, and that's pretty standard in most practices. And then I put in here non-smoking status. We won't do surgery on a smoker. It's ASMBS recommendations not to do that. Smoking can cause irritation to the stomach lining. And when you cut the stomach tissue, you want that tissue to be healthy and to heal well. And smokers have a lot more complications from their bariatric surgery. So we require that you're 2 months free of any nicotine. So what can you expect with bariatric surgery? This is some of the improvements that Dr. Gluck mentioned over the years of research and just optimizing surgery itself. A lot of patients go home the same day now that they have surgery. You might expect a one-night hospitalization, otherwise just for observation and making sure that things are going well. Dietary restrictions are really important after surgery. We want to make sure that those stapled connections stay intact and they don't break open. So you will be on some liquid foods for a few weeks, and then those will advance to soft foods, followed by solid foods and fruits and vegetables. We talk a lot about protein and how important that is. Protein will help us to maintain our muscle mass when we're losing dramatic weight, and we want to lose the fat, not the muscle mass. So we really hone in on protein, but in a safe way to allow you to heal. You will see us a lot after bariatric surgery, or your bariatric office will see you a lot after your surgery, initially to make sure that you're healing well, but then beyond that, to make sure that you're progressing with your goals. In our office, we say once you're our patient forever, because obesity is a chronic disease. You can expect that you're going to have to pay attention to these things long term to stay healthy and to keep your weight off. In the first year, we'll monitor labs pretty routinely. As you're losing dramatic weight, we want to make sure that your nutrition is healthy with all your vitamin levels, your iron levels. Also test your kidney function, your liver function through that weight loss and dietary restriction to make sure that you're staying healthy with that. So close attention to diet, close attention to your fluids, hydration, and then lastly, exercise. And that's probably one of the tougher one for a lot of patients as we come into the office and we have struggles with our joints and with difficulty breathing because of the excess weight. Starting somewhere is really important. Long-term after surgery, exercise will help us to maintain the muscle mass and build muscle mass, which then helps us to drive our weight down even further. Additional things to consider or to look at after surgery, you will hear us say over and over that surgery is a tool. And it's really important that you use the tool to get what you want. One thing beyond diet and exercise is the emotional piece of obesity and food relationship. I can't tell you the number of people that I talk to that have stressful jobs or that have challenging family situations, and that stress and that depression, poor sleep, just not having a good work-life balance, that can influence not only your eating, but also hormonal levels in our body called cortisol that make us hold and store food and calories, for lack of a better explanation. So managing these emotional eating episodes and managing just underlying stress in your life is really important to long-term success. Part of that is developing a support system. We have support groups every month at our office that our bariatric patients are invited to engage in. You can get around other bariatric patients who are walking that same journey. If you aren't comfortable in support groups with others, then maybe you just pick your own. Find a coworker, find a family member, find a friend that loves you and is an encourager to you and will support you through some of the emotions of weight loss as well as the physical needs that you have to meet. This can be a difficult thing, but setting realistic expectations. I hope that the scale is a part of that, but I hope it's way beyond that for patients that we see. I say over and over that our goal is wellness. Our goal isn't a number on the scale, but to be well in our minds, to be well in our bodies, to be well on the scale, all of those fall into that realistic expectations. It's without saying prioritizing the lifestyle, committing to that, staying motivated towards that. That's what's going to keep your weight off. I see people shortchanging themselves a lot to help others, and they kind of have that personality where they put themselves last. And it's something that a counselor could probably help you to see and to realize so that you have a better chance of keeping your weight off long term. Taking the next step. When it comes to bariatric surgery, there's some important things. Dr. Gluck mentioned that we are MBSAQIP accredited. That is a huge organization that looks to the quality of surgeries and the outcomes to make sure that the surgeon is safe in what they do. Blue Distinction Center, it kind of puts all the levels up here. If you can meet their criteria, that's a pretty good center to go to, that they are watching things closely. A multidisciplinary team is without saying. If you have a surgeon that does your surgery, understand that's not the end of it. You need to have close follow-up either with PAs or nurse practitioners or the surgeon themselves. You need a registered dietitian. It's important to have somebody helping you with the exercise barriers that you might have, and different behavioral health counselors and therapists to work on the emotional piece of the relationship with food. Most importantly, you want a surgical office that's going to have a long-term commitment to you, because bariatric surgery doesn't necessarily equal weight loss. It's a long-term commitment. Obesity is a chronic disease. So medications, it is a really exciting time in obesity management because there's a lot on the horizon coming, but they're not there yet. This is a slide that shows the red line here is bariatric surgery. You see a very steep decline in weight in the first 6 months, and then kind of sustained weight loss with a little bit of weight regain. When you look at bariatric surgery, this is that number I was referencing, you're going to see 25 to 35% of the total weight that you carry come off. And when it comes to medications, and these are pictured up here with the most successful one being tirzepatide or Zepbound, you are looking at 15 to 20% weight loss. So put that into practice there. You got a 300-pound 5'8" male, and he's going to lose 45 to 60 pounds with the weight loss medicine, landing him 240 to 255, versus surgery, you'd expect him to lose 75 to 100 pounds. So still a long way to go with the medications to equal what we see with surgery. This is another image in a different way. A Roux-en-Y gastric bypass hitting 32% total body weight loss, a sleeve 29.5. Tirzepatide, Zepbound, 15 milligrams, the highest dose, 20% weight loss. Highest dose of semaglutide, which is Wegovy, we're at 14.9%. And then we get into liraglutide, which is Saxenda, the original GLP to the market for weight loss. You're at 6%. So they have gotten better, but there's still a significant distance between the medications and bariatric surgery. Some of the barriers that we face with patients who are on medications is insurance, and some of you might have experienced that already, where these medicines cost upwards of $1,000 to $1,300 for a month's supply. And so you extend that over a course of a year, and you're about $15,000 a year for therapy. And this is not just to get down to the weight and stop the medicine. This is a medicine that has to be maintained in order to keep the weight off. So the cost difference between bariatric surgery and weight loss medicines is significantly better on the side of surgery, honestly. And to some degree, the hassle of going on and off the medicines because of your insurance company barriers and restrictions is kind of overcome with surgery. So this sums it up there. Researchers say that weight loss surgery is still your best option for losing and sustaining weight. And then you can lose weight, but you will regain the weight when you stop medications. And I have this additional slide that talks about, we see significant weight loss, yes, with weight loss medicines, but when it comes to the risk of death, we know that you have huge improvements in cardiovascular disease and cancers with bariatric surgery. And we just don't have that long-term data yet with our injections. So weight loss, 20% of weight with our medicine, up to 77. We said earlier, 68 to 70% with weight loss surgery. Weight regain, you see about 7% over time with bariatric surgery, but once you stop your medicine, you're going to gain upwards of 70% of your weight back. The medicines require a continual usage. Your bariatric surgery is a one-time procedure with long-term follow-up. Bariatric surgery safety, been studying this well over 20 years. And as Dr. Gluck said, the Roux-en-Y gastric bypass has been around since 1966, so it's certainly not anything new. Diabetes, 80% resolution with bariatric surgery. We see a 1% decrease in an A1C level with our medicines. And then here's a big one, cardiovascular risk reduction, 26% with our meds, 79% with bariatric surgery. So takeaways, I hope what you heard in Dr. Gluck's presentation in the video is that obesity is exceptionally complex and it's a chronic disease. Obesity will contribute to many dangerous diseases that affect your body. It affects your quality of life. It absolutely will end your life sooner than if you have normal weight. But the takeaway is obesity is treatable. Bariatric surgery still remains your gold standard for managing and treating chronic obesity, but only 2% of eligible patients pursue surgery. Obesity is a disease, it's not a choice, and we see a lot of patients who come in pretty full of shame and guilt because they've been made to think that obesity is their fault. But again, take away that video and understand that there's so much behind the scenes with hormones and different environmental factors that drive that weight up. But you do have a choice. It's fun to share some pictures of patients that we've worked with. We've got one gal who's a professional water skier. We've got some of our patients participate in these cardio drumming groups and like to lead others in that exercise. I had a 70-year-old lady was excited to get under 200 pounds so she could jump out of a plane. We took a group of our patients up to the Muskegon State Park, and we did some luging with them and got to celebrate with them as they were able to lose quite a bit of weight and enjoy some of those recreational things. This is one of my patients who lost so much weight that this was when she went with my partner and I, Riley, the other PA, for a walk. She was able to walk 2 miles with us that day and had never been able to do that before. And you can see this picture here with the patient holding up her pre-op jeans that she wore. Just unbelievable to think that this woman fit in those. So this is some contact information here for Trinity's bariatric program. Phone number, you will contact us through that, or there's a QR code that you can scan to access the Trinity website. And we are happy to take any questions that you might have about surgery or outcomes or anything else on your mind.
Thank you, Dr. Gluck and Tricia. That was a wonderful presentation. As Tricia mentioned, we'll now transition into our Q&A session. If you haven't already, you may submit your questions using the Q&A chat feature at the bottom of your screen. And I do have one that we can get started with. Is a physician referral needed for bariatric surgery?
It probably depends on the insurance. So, you know, some of the HMOs will require it, but most commercial insurance companies don't. We always like to have, you know, certainly a letter from the family doctor.
If you call that number, usually there's an attendant that can kind of help you with your plan too, and they'll let you know if your policy would require that.
Perfect. I think that actually answers, you can agree or disagree, our next question, which is, are there any insurance requirements or coverage options for bariatric surgery?
Yeah, insurance is pretty great with covering bariatric surgery these days. Very few plans don't cover it, but they do have some requirements or guidelines that you have to meet in order to be approved for surgery.
Right, yeah, but again, I think these insurance companies are seeing that bariatric surgery right now is still a lot cheaper than, you know, putting somebody on lifelong GLP-1 drugs. You know, I think the GLP-1 drugs will come one day. You know, one day you're going to have an obesity medicine, a pill just like you take your hypertensive medicine that you take every day that, you know, prevents you from, you know, gaining your weight back or you know, keeping your weight off. But it's just not there yet, and it's certainly not going to come for a while. You know, but again, right now, most insurance companies feel that, you know, they're willing to pay for the surgery, and even more so since these GLP-1 drugs. And some facilities, like we do, we have a very reasonable cash price for patients who don't have insurance coverage, and you know, the cash price includes the surgeon fee, the hospital fee, and anesthesia fee, and so we have many patients go that route as well.
All right, thank you. And the next question is asking, how will I know which type of bariatric surgery is right for me?
Well, I think that's a conversation with you and your surgeon, and you know, exactly something that really you need to sit down with the surgeon and you know, find out certain things. You know, do you have bad reflux? Are you diabetic? And really what, you know, what your BMI is. So that's just, I think you go have a consult and talk to the surgeon, and see what you both feel may be best for you.
Wonderful. Thank you, Dr. Gluck. Our next question, and I do believe you touched on this a little bit already, but if you wouldn't mind summarizing again, I apologize for the feedback. I'm not sure why that is happening. Let me know if you can't hear me though. The next question is, what is the process for preparing for surgery, including any required tests or lifestyle changes?
So, here, we want patients to, come on board with this, and surgery is a lifestyle change, and we want to know that, you're willing to do these things. Sometimes when I see a patient initially for my initial consultation, and then they go through the process, and we see them again at the pre-op appointment, 3 weeks before surgery, and the patient has gained significant weight since the time I saw them, that tells me they're just not ready for surgery because they've had their last supper every night. Whereas we want people who try and get on board when they decide that they want to have surgery and make those simple lifestyle changes. We don't expect you to lose a lot of weight or anything like that, but you certainly want to start, maybe making some better food choices, try and doing some kind of exercise. So, some insurance companies require a 6-month physician supervised dieting, where I know a couple of the insurance companies, if you don't lose 5% of your body weight, or even if you gain weight at one point during that 6 months, they won't cover your surgery. But most of them don't have that hard criteria.
Smoking cessation, as I mentioned, you have to be 2 months without cigarettes and any nicotine. Alcohol, you can't drink alcohol about 6 months after surgery just to allow for healing. And so if alcohol is a big part of your lifestyle, I would recommend that you start to manage that and really reduce that intake before you have surgery.
Thank you both. Our next question is asking, how do I know if I'm emotionally ready for the changes that come with bariatric surgery?
Well, I think that's something that, we have a psychologist who will do a review with you. And that's again something that you could talk to with your potential bariatric surgeon. Chris, you want to add to that?
Yeah, one great thing, I know we're not the only office that provides support groups, but the minute we see somebody for a consultation, we invite them to attend those support groups. I think it's just, you're on there with people who have maybe already had surgery or who are getting ready to have surgery, and you can talk with them. And they're a great resource for patients who are going through this. If a person feels like they're not ready, we're more than happy to meet with them monthly for a few months or however long they need, just to feel confident that this is right for them and they're at a point where they're ready to go through with it. I have some patients that have, even though their insurance didn't require it, but they said, can I just see every month for the next 3 or 4 months and just kind of make sure I'm doing the things I know I need to do. And I think that speaks very highly of their commitment. And I often think they're probably the ones that are going to do better because they're real about it.
Thank you. I'm sure you might get this question often from patients that you're seeing for the first time, but we do have someone asking, why am I so fearful to lose the weight?
Well, I mean, again, there's different reasons why people want to hide behind their obesity. We see that a lot in women, especially women who were abused, sexually abused, in their early adult life or early life. And so that's pretty common that, they don't want to get that attention from the opposite sex. We see that often. Trish, you want to add to that?
Yeah, I can kind of speak to, I think a lot of patients are afraid that they're going to fail, and that's not unwarranted. Most patients that we see have tried endless diets. They're professional dieters by the time they see us, and maybe they've lost some weight, but they can't keep it off. And that's, as that video explained, that's just such a part of our body's physiology to defend that weight. And so people come in with this kind of battered self-esteem and just kind of a sense of a failure. And I think they just kind of are worried or fearful that they might not be successful. And again, I think surgery, when you look at that video, it speaks to why it's so much better than diet and exercise that fails 95% of the time. I tell patients sometimes when it comes to diet and exercise, it's a great preventative way to handle our health. If you diet and exercise regularly, you'll prevent obesity. But once you are significantly obese, that's not necessarily the best treatment plan. It's like a smoker who gets lung cancer. Stopping smoking isn't going to fix their lung cancer. They're already damaged. Now we need a treatment plan to come in there to fix the disease that's occurred. So you got your lifestyle management, and even though that's failed you, it's not your fault. It needs a therapy beyond that. And so that would hopefully be something that could get somebody listening to take a step.
Wonderful, thank you. The last question that I am seeing as of right now is, what is the typical recovery time after surgery?
We tell patients that we like to keep them off of work. I tell them typically 3 to 6 weeks, but everybody's different. You know, I think everyone knows how they feel after, how they feel post-operatively, and everybody does different jobs. You know, if I do 8 surgeries a week, 8 people feel 8 different ways. You know, I have people who have a desk job and they go back a week after surgery. I have people who, you know, lift heavy things, and I don't like them to go back for 6 weeks. So really is, you know, I think we're very flexible. It just depends on how you feel in your job. But typically 3 to 6 weeks.
Wonderful, thank you. Well, that is the last question that I am seeing. Should you have any additional questions, please don't hesitate to reach out to that 844-423-7564 number. Thank you once again to Dr. Gluck and Tricia for a wonderful presentation and insightful Q&A. To all of our participants, thank you for joining us, and we hope you have a wonderful rest of your evening.
Thank you.
Thank you.
Thanks for having us.